more people than
No way. No. Ventilation.
Just don't go anywhere near
The
fire.
water goes
Yeah,
there.
I smell it now. They float away. I've had that happen.
Really?
I was walking in the ocean, like on walks and stuff, and one foot slipped out, and next thing I know, they're floating.
Well, see, were you in comfy mode or were you in tactical mode?
No, it's sport mode or convertible.
No, it's tactical.
I was in comfy mode.
Where are your studs, bro?
Studs?
The little token things.
Oh, the
Oh, yeah.
giblets.
The giblets. Wait, they're actually called giblets?
Yeah, giblets.
Gotta put a
Yes,
hat
giblets.
on.
Giblets.
Try again.
Should be.
Dude,
Really?
are you shitting me?
Really?
Yeah,
That's right.
The transition from parking to accident to
Yeah, but you know, Bill, that's probably related too.
It was over the parking.
They've been bought, you know, that's part of the consolidation in the ski industry. There was an article in, letter to the editor,
I've actually never been
camera. Got a guy saying, please don't buy the icon gas because
I've never
he's
seen
talking about how copper is more
I've never
expensive
seen
and ore and that sort of thing. So, this is just, I mean, is it really to discourage people from driving up there alone, or is it a ton of bucks? Yeah, it's money. So I think it's part of it.
Just for sheet.
And you coordinate that with.
Okay. I just need to know what notebooks are around.
Yeah.
Can somebody get D4H working in the back there and log everybody? Oh, then do you want to do a CV roster? Did you guys have CVs for this?
Yeah.
Yeah.
And what was the answer?
With the coordinated.
So is that like a heavy JD?
If you have to click on the BES, you need some BES page.
Simon, I got an interesting email the other day.
Yeah.
You know Sam Morris?
Yeah.
Wants me to be a lieutenant next year. For
Yeah.
CUEMS.
I heard.
Why me?
Why me?
Yeah, why me? I've never had a conversation with her in my life.
What?
Why did she ask me, is what I'm saying.
Why didn't she? Who asked you?
She sent me an email.
Sam Morris?
Yeah.
Sam was a guy. Really?
John,
Isn't Sam a little small kid?
Blonde girl. She's running for Zach's, she's taking Zach's
Yeah,
position.
that's right. That's right, I remember that now. Yeah. That's the other Sam.
Why are you doing it?
Because I don't want to be kidding.
No, like, why did she ask like you to be a
Yeah.
lieutenant?
I already am a lieutenant.
Oh, are you?
Under Haley.
Oh, yeah.
Oh, so you do that. So you're gonna
She
go.
wants, she said she needed me to help like run events while she's in Chile.
Oh, I did, yeah. Yes, it's all coming back. Chile.
I can't change anything.
You went to Chile, didn't you? This summer, man?
No, we don't go in this one. We go in the winter.
Last year?
I'm going like a week yet.
And
I went
Nick,
last year too.
Nick, do you think we'll be able to get CDs for this?
My favorite spot right now.
I'll take
is
down whoever needs it.
Kind of old Blue Sky Basin in Aquavale.
The thing is, everybody who signed up,
I had
so I'll
to
just
send it
get,
to Jeremy to get it approved first.
I'll just get started here since everybody's here except for one person.
Yo, bitch, you still can?
So we're gonna do a couple of different things tonight. I hope to get this through pretty quickly. Again, if there's any questions or anything, the pertinent ones I'll try to answer while I'm going. If there's anything that's kind of a little bit off topic, but you still want answered, write down on that board right there, and we'll see if we can't get to it afterwards, after the training, just so we don't draw things out too much. So first of all, we're just gonna do a little bit of hypothermia drowning, kind of our bread and butter, things that we see day in, day out on all of our different calls. We'll take a little bit of break. We'll see how much time is, how fast we're going through. This shouldn't be too long. And then we'll do our quick little intro to TECC. Then we're going to go out into the bays and do a little bit of patient assessment skills. As far as medical kits, I see 2 of them out, 3. Cool. So a couple different ones. We'll pass those around and we'll have people look at things when we get to that section. And then unfortunately, we just don't have any training tourniquets. So, we'll show, well, that situation will be changed pretty soon. So we'll do an actual tourniquet training, but for now, we'll kind of just talk through and go through the motions, and then we'll go from there. If there's any acronyms or anything that you don't understand, please let me know. Medical types and all whatnot like to use acronyms, so I tried to take all those out. Any questions before I get started? All right, so I like to use that as a pointer. Hypothermia. How many of you guys out there have been hypothermic at some point? Okay, so what would you describe how did you feel when you got hypothermic? What are some of the symptoms that you start to feel?
Shivering.
Shivering, yeah, that's the first one you get. Tingling, numbness, paresthesia, technical terms. Okay.
Fatigue.
Yeah, fatigue. Yeah. So has anybody been really, really hypothermic? No? Okay. It's a pretty interesting experience. I got pretty cold enough where I had to stay in a hot tub for about an hour to get to feel like I wasn't super cold, but I didn't feel warm again. So, yeah. Hypothermia is defined as a core temperature below 35 degrees Celsius. That's 95 degrees for the rest of the world. It can happen in any sort of different.
I'm sorry, just real quick, just so you know, the live stream video says it's been removed.
Yeah.
You're trying to live stream.
Technical difficulty. I'm streaming it, so you have to go through our video page and.
Oh, okay.
Yeah.
Sorry to interrupt.
No worries. So any temperature below 35 degrees is considered hypothermic. And that can be seen in anything from environmental exposure, so a lot of us tend to think in the wintertime, ice water, anything like that, but it can be year-round. I've seen a lot of people start to get hypothermic when they're diving in the summer in 85-degree water. 85 degrees is less than 97.6, so just that little bit of change takes a little bit more time, but you can see hypothermia almost anywhere. So there's two big major types of hypothermia. There's primary and secondary. Primary is generally the one that we're dealing with. It's the acute, rapid onset. Somebody falls in the cold water. Generally environmental. I put that picture down there in the corner too because that's also something that we see quite a bit on the ambulance. Is older people fall, they can't move, they're on a tile floor or something like that. It's a warm house, the heat's on to 75, 80 degrees. But still, after a long time, that conduction of the tile and everything sucks the heat away, then we see hypothermia. Secondary is generally something with some pre-existing illness, where we kind of start to see secondary trauma. We'll talk about it in the next little section, but is trauma. So any sort of compromise of the body's compensatory mechanisms. If the person's in shock, then they're very much more susceptible to secondary hypothermia. So, a couple different stages. It's not really important to memorize, 37 degrees, 35, 32. Just remember it's a progression. The body kind of has a bell curve to how efficiently it works. So on either extreme, too hot or too cold, it's going to be inefficient. The body needs a very narrow range of temperatures for things like muscles to work, nerves to fire appropriately, your heart to beat normally, all those different ions shifting across cellular membranes, that needs to happen at a very specific temperature range. When you get outside there, things slow down, things are inefficient, it doesn't work as well. So when we talked about, the tingling, the numbness, the fatigue, the feeling like your hands can't move very well, muscles stiffening up, that's all because you're starting to fall outside that range of temperatures. Again, just remember, the only number, if you have to remember, 35 degrees. That is kind of technically our hypothermia. So that 35 degrees, you're going to see that vigorous shivering. That's the shivering where the person can kind of stop for a little bit, but they go right back into it. The kind of big differentiation between mild and more severe forms of hypothermia is when the person cannot stop shivering at all. The colder the person gets, things like Mental status and muscle movements are gonna start to decrease. So you're gonna see people with altered levels of judgment. You see that in a lot of, like adventure races or, like endurance sports, especially in the winter time. You see people keep pushing and pushing and pushing until they're way too far. So, other things, Amnesia Dysarthria, that's something some of us suffer normally. Dysarthria is difficulty speaking, difficulty physically moving their mouth to make words. Amnesia, forgetting things. So they forgot they passed their check marker on the race, or they forgot to, I'm going to take this exit, or this, I'm going to take the ski trail down to get back to the lodge, something like that. Ataxia, that's one where you start to see, it's just people's coordination. So it's partly to do with their muscles moving, but it's also has to deal with their brain and how it works. So in order to reach out and pick up something, there's a lot of different processes that go through. Your brain, your eyes, so the information comes into your eyes, gets processed by your brain in the visual section, then it gets sent to a different part of the brain that tells your muscles how to do things. There's input coming in from your hand telling you where in space your hand is, so you can and there's all that different coordination going on. So again, you get in those extremes of temperatures, all those different processes start to go a little bit out of whack. The colder you get, the more difficult it is. So you'll see people have difficulty standing and walking and balancing, all different things that we'll start to see. For the most part, people in this range of temperatures are going to be pretty stable. They'll be able to, they're not going to be hypotensive, low blood pressure. They're not going to be, super bradycardic or tachycardic. They're still able to think and talk and move for themselves and generally take care of it for themselves, but we're starting to get a little bit concerned. So we're going a little bit further down the progression here, getting colder. We're going to start seeing hypoventilation, so people not breathing very rapidly, or so they're going to start breathing slower than that 10 to 20 range a minute is the normal standard range. We're going to see people, their reflexes are diminished, so that again, their brain's not processing that information very fast. It's starting to get inefficient. And then when they really start to get cold, this one, I'm sure a lot of you have heard of paradoxical undressing, hypothermia patients. The body, so one of the compensatory mechanisms that the body has, when you start to get cold, your capillaries, your little tiny veins and vessels, start to shrink down and squeeze and try to squeeze all that blood from your periphery into your core. And that's your body's way of trying to keep all that heat centrally. So again, when you start to get cold, you feel your fingers and toes start to go numb. That's another part of that equation. Paradoxical undressing happens when the body is so far down the line, it can't keep those vessels squeezed, so then they dilate. All that warm blood goes from your core to your periphery, to your skin, and that's when when people start to feel really hot, like they're burning up. They take off their clothes, and that's about the time when people really start to go downhill and go unresponsive pretty quickly. Any questions so far? All right. Great time. And then another really big milestone is that the patient stops to shiver. That is a really big one. That means that the person is no longer able to do anything to help themselves get warm or stay warm. Shivering is a really good way to help keep that muscle activity going and have that thermogeneration. So have your body metabolize all the nutrients and turn it into heat. Then down from there, altered mental status, coma. The heart, like I said, it stops to conduct very well. You'll start to see some abnormal rhythms. I'm not going to get too deep into all the squiggly lines here. And then at the very end, pupillary dilation. That means that the neurological, your brain's pretty much not processing any information at a very rudimentary level. For us, when we check pupils on people who are unconscious, unresponsive, and we don't see any reaction, that's generally a sign that there's no neurological activity going on. So people, especially like CPR or a pronouncement or something, I'm always going to check my pupillary reaction. If I don't see any, if they're fixed and dilated and there's no reaction, that's going to start to tell me things. But that kind of leads into people who are really cold can look like they're dead. That's very difficult to differentiate, and unless there's physical freezing. So, next slide. Below, again, their heart's not beating very well, so they're very susceptible to going into lethal rhythms, non-perfusing heart rhythms. That's ones that we do CPR, we shock them. We start to think about more advanced procedures when we go into that. Their heart stops, their heart isn't as able to squeeze as hard, so they're not going to be able to have as good of a perfusing pressure for their brain. So you might just start, you'll see even more altered mental status, and then like all those different things I just covered. So, let's say we've got our patient right there, we've pulled her out, she's not in a ice rescue suit. We've got a patient who's severely altered. They're not able to respond to you, they're not able to follow their commands. What are some things we want to consider and assess it and evaluate?
Do they have a patent airway? Unlikely if they're unresponsive.
Okay, so in this case, our patient is breathing by themselves, they can talk, but they're not making sense, they're AO times 1. So, for the non-medical people, AO times 1, awake and alert, generally say person, place, time, and events. Times 1 is probably like to name only, so they only know their name. What are some other things we want to start thinking about for an altered patient?
You want to get them out of the environment.
Yeah, get them out of the environment, stop the injury process. Just like burns, damage is happening. We have to stop that damage from happening. Of course, it's not as fast, it's a different mechanism, but, so get them out of the environment. Davros, there's something out, altered patient, what do we check?
Yeah.
BGL. Is this simply hypothermia, or is this something else? Is something else going on top of the hypothermia? Did they get really altered by their own means, so alcohol or drugs, go out on ice and fall through and go in under, and then they were so altered they couldn't get out? Were they walking out and then they slip and fall and hit their head? And then did that cause them to be altered and not be able to get out? We don't know that whole story without seeing it actually happen. So we have to consider all those different things. Check for a pulse if they're conscious and everything doesn't matter as much. But C-spine. Do you guys, Davros, you work in Boulder County. What's the modified C-spine precautions? What kind of patients can we clear for C-spine?
Spinal pain, and then if they have, we put a C-collar around them.
Okay.
What do you
So what patients can't we clear?
Patients with deformities in their neck.
Okay. Keep going.
Deformities, pain,
Right there.
altered.
Altered patient. They're not a good historian. They can't tell us what happened. They only know their name. That starts to tell us, hey, we got to really start thinking about what else is going on. And then of course blood glucose, we already covered that. Hypothermia, the squiggly lines. It's probably going to be Chinese to most of you guys. It's very complex, but again, electricity is not flowing as well. The heart, to be able to beat, the heart works on electrical potentials across cell membranes. You have to have ions flowing back and forth. The cold just messes things up, and your squigglies look too squiggly, and it'd take a very long time to explain all of that. So, hypothermia. What do you guys see here? What's going on?
Took all their clothes off, and now he's in a burrito or some kind of
Yeah,
foil heat blanket.
yeah, medevac. And that's something that we see all the time. Our big trauma patients. What's one of the things when they tell you to treat for shock? Trauma naked, which we take away their thermal insulation. What's one of the next steps to prevent shock? Keep them warm, get them warm. We want to prevent further heat loss. Same thing with hypothermia. Again, you don't have to be pulled out of the ice to be hypothermic. You could be a trauma patient. Somebody who just had a major vehicle accident, they got ejected, and now, they're laying on the cold road. We just took off all their clothes to do our trauma assessment, and it's raining outside. Then they're starting to get hypothermic. So we want to stop that, prevent further heat loss. Wet clothes, something like that. Take off all their wet clothes. We want to treat the patient very gently. Like I said before, all the electrical potentials in the heart, they're very the heart becomes very sensitive and it gets pissed off that things aren't in that perfect little range. It's like Goldilocks, it has to be just right. When it gets outside the norms, either too hot or too cold, any sort of rough handling can send it into one of those lethal rhythms. It starts to beat too fast or just uncoordinated movement. So really gentle handling. We want to use a backboard, a Stokes litter, and we really want to make sure that we don't jostle them around as much. When we set them down, it's very gentle. We're taking extra careful care of these people. Treatment, of course, we want to stop the injury process, and then we want to start with external rewarming. We're not doing super hot IV solution. We're not throwing the patient in a hot tub. We're not putting heat packs, packing them in a sleeping bag with heat packs. The biggest thing is we want to make that nice gradual rewarming process, especially when they're on that colder end of the spectrum. If you throw somebody who's really hypothermic into a hot tub, sure, it's going to rewarm them, but that's a huge stress on the body. Whenever you get outside of the norms on something like electrolytes or some sort of imbalance, including hypothermia, like an extreme of temperature, rapid correction can lead to a lot of extra stress on the heart and on the body. It's something we want to really avoid. So anytime you have somebody in one of those extremes, it's always really close monitoring. That's why we don't have insulin on the ambulance. It's really easy to give somebody too much insulin and then we just push them over. So we really want to be able to titrate to effect a nice, slow, gradual change, so we're not shocking that system. So that primarily concerns of internal rewarming, so we're going to use warm, not hot IV fluids. We're not using something that's cold that we just pulled off the shelf. Then mostly supportive care. If they need a little bit of ventilation, we're going to ventilate. If they need something for pain or comfort, we're going to take care of that. And then we're just going to, take them to the hospital nice and gentle, no bumps, go from there. Any questions so far?
As you're rewarming them, you have to monitor, I guess, for just like a crush injury where you're getting all those toxins flowing in when you pull them off. The same kind of stuff is going to happen from the extremities. Okay.
And I thought I had that in my presentation. I might. But what Paul's referring to is the rewarming phenomenon. So when your body clamps down with those capillaries, it's almost like a crush injury. So the perfusion to your limbs and your skin and your muscles, non-essential organs, or non-essential tissues rather, really slows down. So that blood starts to kind of pool and stop flowing. When you start rewarming that patient, those capillaries and those small veins and arterioles are going to start opening up. That cold blood is going to dump right back into the system, and it's going to be slightly acidotic because it hasn't circulated. You haven't oxygenated that blood, and it's going to be really cold. So then you can get what's called a secondary sort of hypothermia coming on, and you can actually make your patient even cold, or just as cold as they were before. So that's another thing we want to consider is when we're rewarming that we want to watch out for that. As far as really, really advanced hypothermia, a lot of these people are going to look like they're dead. They're not going to be breathing. There's going to be no detectable pulse. There's going to be no activity in the pupils. They're going to be unresponsive, painful stimuli. They're going to look like they're dead. So I'm sure people have heard that you're not dead until you're warm and dead with hypothermia. That's a big reason is, a dead patient looks exactly like a hypothermic patient. So we're going to work them. We're going to do, as far as the advanced life support, we're going to do one round of epi. We're going to do one round, if they warrant a shock, we're going to try shocking them once. But the big problem is that they need to get warm again. And a lot of times with these patients, with rewarming, their vital signs are going to start to come back. Their EKG is going to start to look more and more normal. The big thing that they need to do is get warm. This kind of goes without saying, but if your patient is actively resisting you when you're doing CPR, you're probably doing it wrong. There's videos out there, some of us have seen them, it happens. Use your best judgment. I always tell people that CPR is a perfect form of painful stimuli if you're in doubt. On one hand, you're pushing on their chest, and it's gonna be good painful stimuli. If they're not responding to that, and you can't feel a pulse, you probably need it in the first place. You'll know within the first 1 or 2 compressions if they're responsive to painful stimuli. So, like I said before, what our care as BLS providers includes is CPR. So making sure that we have high quality compressions, making sure that we're ventilating really well. If we have any sort of King Airways or oral airways or something like that, we get those in place. High flow tube. We want to get that patient out of the environment, get them out of their clothes, start working on that passive rewarming. Turn on the heat in the back of the wherever we are. If we're in Sarcom or if we're in a vehicle or something, we want to get them in the heat going. We want to do that supportive care. And then ALS, advanced life support, we want to start to get that process going. We're not definitive care. Definitive care is at the hospital, where they have this really awesome heated blanket. It's like they circulate air, and it's like an air mattress, and it's great. So that's really definitive care. If it's really bad, they can start to circulate warm fluid into their abdomen with different little ports and start to rewarm them internally that way at a very controlled pace. So again, they're not dead until they're warm and dead. And don't delay transport. Once we've identified this patient's critical, there's no reason to stay there on scene and keep working on them. Like, we're not definitive care. We need to get them moving. Again, gently, easily. We're not scrambling, but we want to move with a purpose. We want to start thinking, what's the next plan? We want to get AMR intercept coming. We want to get flight for life, if that's a possibility. We want to figure out how we can get better care to this patient to better care.
Hey, Nick, what rate do you, if they are severe or anything, what rate do you raise your temperature, like 1 degree per hour, I think?
I don't remember that number. Off the top.
Slowly.
It's slowly, yeah. The big thing for us pre-hospitally is that we're not doing that super hot, like I said, we're not throwing them in a hot tub, we're not pouring in super hot IV fluid in. It's all warm, it's slow, it's gradual. Justin?
Would a medic push sodium bicarb to combat that acidity that Paul was talking about?
It's not in our protocols.
Yeah.
I wouldn't. Again, the big problem is cold, and for the most part that happens later in the process once they start to get warmer. Sure. And by rewarming them nice and slowly, we can kind of help, instead of having those veins just blow open and start to dump all that acidotic blood and cold blood, we can have it more of a gradual process where it happens over a longer period of time, sort of a little bit more like a big bolus. Gotcha. I actually had this in my presentation. So the after drop phenomenon. So rewarming, peripheral vasodilation. So peripheral, kind of farther up from your core, so your hands, your feet, your arms, your legs. The cold blood and cellular waste are carried back to the core. Drop in core temp, acidosis. So the blood is physically more acidic. There's more carbonic acid. There's more carbon dioxide dissolved in that blood, so it drops the pH, and then it can lead again to lethal arrhythmias in a heart that's already stressed out because it's cold. One of the big stories that a lot of people have heard that really plays to they're not warm until they're dead until they're warm and dead. So in '99, this Swedish or Norwegian skier fell in the water. She was underneath the water for 80 minutes. What's our cutoff time for rescue versus recovery? 90 minutes. So it's pushing right up against her. And I think there's actually been a more recent case that was like 120 minutes. It was pretty long. But so her core temperature fell to 13.7, 56 degrees Fahrenheit. Yeah, so very profound. So she was able to find a little air pocket. She went into cardiac arrest for 40 minutes. 40 minutes. That's a very long time. My protocols say if I'm doing CPR and somebody in cardiac arrest, I have to work them for 30 minutes and then I can call them. That's normal. If they're hypothermic, they're not dead until warm and dead. So 40 minutes is a very, very long time for your brain not to be perfused. But, one of the things I said, all your processes start to slow down the colder you get. It does pay an advantage to you. So the slower your muscles go, the slower your heart goes, the less they're metabolizing that energy, the less wasteful byproducts they're putting out, which means that the less oxygen demand you'll have on your circulation. So things like your brain, your brain needs an incredible amount of perfusion to be able to maintain conscious thought and do all the different processes it does. And if it doesn't get that, you start to get altered, you start to pass out, decrease in level of consciousness. So it really does play and help out. So she was flown to ICU and she made a full recovery with some just very minor peripheral nerve damage. Incredible. 80 minutes underwater with 40 minutes of cardiac arrest. That's incredible. So it's really difficult for us to be able to call that on scene. More often than not, we're going to transport these patients out. When we do, there are some limits, however. We don't work everybody. If we pull somebody out of the water and they physically have ice frozen in their airway where we can't manipulate it and get an airway in, or if we're trying to do CPR and their chest wall is frozen rigid, that's they're beyond help at that point. So that's really when we can stop doing our considerations and it turns into a case for the coroner. Any questions on hypothermia? It's about 25 minutes in. Does anybody need a break or push on to the next section? All right, so drowning. Again, it's something that we see a lot. Hypothermia and drowning go hand in hand. Like I said before, anytime that water is colder than your core temperature, you're at risk for hypothermia. For the divers out there, how fast does water conduct heat faster than air? 25. So yeah, you can if you've ever walked outside and it's below zero, you can stand up there with just a t-shirt for a couple minutes before you feel real chilly. If you jump into a cold pool of water that's right at freezing, you're not going to be happy if you stay there for much more than a couple seconds. So technically speaking, drowning is respiratory impairment from submersion in a liquid. So either it could be they fall in the water, it could be they somehow had water poured in, it could be secretions coming out of the lungs and filling up the airway. So a couple different mechanisms. It's not just falling in water. They used to refer to it as near drowning and drowning. They've kind of gotten away from that terminology. It's now active versus passive, the way they're referring to things. So dry drownings happen very rarely, but that's when the water hits your oropharynx, the kind of back part of your throat there, and your larynx clamps down to protect your airway, and it prevents water from going in. These are extremely rare. I've seen one in the field, and we don't even know how it happened. But and so the opposite of dry drowning, obviously, wet drowning, and that's when the water goes into your lungs and contaminates it. We do have a couple considerations here around here. We're just going to see fresh water, but the fresh water is hypotonic, so it doesn't have a lot of things dissolved in it. And the way osmosis works, it's going to draw fluid out of your body to help. No, it's the other way around. It's going to push water into your lungs to help dilute the brain fart here. But osmosis, it goes from low concentration, low to high. Wow. Salt water does the opposite. It's going to draw fluid out of the lungs. It's going to pull it's going to damage those cells, and it's going to provide a lot of damage. Something else we want to think about too is what's in the water. If there's a lot of bacteria, if there's a lot of crap in there, if the patient makes it out of it, we're gonna have to start to think about things like pneumonia and infections. It's gonna be a lot of different things, so. Like I said, 15% for dry drowning, not very common. So, once you go underwater and you physically have that blockage of airflow in and out of your lungs, you start to get hypoxic. If you're lucky enough to drown in cold water, that starts to cool down your central nervous system, and like I said before, it helps slow down your metabolism, it slows down your metabolic demands, and it really helps protect you in the end. But there's only so long that can help you out, and eventually it all leads to cardiac arrest and death. Again, that will cut off warm water, cold water. 75 degrees is what DRI likes to say, or 20, rounded up at 24 degrees Celsius for us metric-minded people. So treatment is rapid and safe extrication. It's really easy for us to really get drawn into the scene and just go, 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 but we really have to think about how did they fall in, and can that happen to ourselves? We've got a lot of training, so let's make sure we kind of keep the mind out on our training, that we're not just rushing in like moths to a flame. If this person's not a good historian, we pull them out of the water, they're unconscious, unresponsive, we have to consider C-spine. That's why you always see spine boards and everything at pools. That's just their C-spine injuries and drowning really go hand in hand. Suction, you're going to need a lot of suction. Clearing out the airway, almost continual suction. You'll have to reassess and really make sure that when we're ventilating, we're trying to reduce the amount of water that we're pushing in the lungs as much as possible. And then advanced airway, high flow tube, that sort of thing. IV with warm normal saline solution. And again, we want to rule out all the other different causes of altered mental status. It's kind of obvious they went in the water, but were they altered beforehand? Cold water and cardiac arrest, like I just said, doesn't need repeating. Warm water, 24 degrees Celsius, 70 degrees, 75, I don't know why I put 74. But when they're above when people drown in warm water, the chances of survival really go down rapidly with every single degree above that 75. So really the colder the water, the better. Let's take a quick little break here, get up and move. Let's be back here at 7:40, and we'll go into the next section. Yeah.
I see a lot of medics put IV fluids on the feeders, in the front.
Yep.
I never see any of them use it. So what are your thoughts about using it? How quick would you let that go and stuff like that? 'Cause I've never seen them use it, but it's always sitting.
Well, in Golden, we actually have IV warmers that work.
Oh, nice.
But
Those red bin things.
any critical patient, like multi-systems trauma, or if somebody's really decompensating, if it's like cardiac patients, something like that, I'm gonna start to think about warm IV fluids, because that's just an extra little bit of stress that we're putting on their system.
Right.
Especially trauma, like it's big, so we want to try to keep them as warm as we can. Keeping it on the dash, like it's right against the window, which
Yeah.
conducts heat away,
Right.
so it gets warmer, but
Yeah. What about like an unwitnessed arrest? You just judge it off the patient's skin temperature?
unwitnessed arrest is generally, IV fluids aren't really in, until we get ROSC.
Right.
Or if
That's
we
what I'm
get,
saying, yeah.
yeah, then actually,
Then
so
more.
for ROSC, we're actually not, we're starting to think
Should
about
be.
TIH. So we're inducing therapeutically induced hypothermia.
Yeah.
So their body is already partially compensating. We've started to hydrate again, but we want to make sure that we don't get those metabolic processes up and running fully completely. So if we can keep them a little bit colder, it's less stress on the brain, less stress on the heart, and it can really help make the
Yeah,
muscle better.
I remember hearing like medics were carrying fridges for a while, but I guess.
We had them for a little bit, but it's just, it's tough in the field. And again, it's one of those things like they can probably, if they get lost, they could probably
deal with it for like 20, 30, 40, 60 minutes until they get to the hospital where they can really do control. And then they'll start to do, I don't know if it's super common, but they put a couple like ports in and out of that. And they'll start to circulate fluid, like warm or cold fluid. They'll do the same thing, they'll take like ECMO once.
Yeah. If their heart's not pumping, maybe it stands for.
You know, like the
Like you said,
external
you're gonna need
perfusion.
So you can push on the.
I call it even corpses basically. But, so it pulls your blood out and it oxygenates it, pumps it back in. But, so they can control some source of that, and then they'll reoxygenate the blood, so you're making sure that if you have lung damage,
I've seen those like the solar platters,
Yeah.
the like inflatable mattresses that they wrap in.
The bear huggers?
Bear hug, yeah, yeah. I haven't heard of those,
I thought it was a J.
I wonder.
But also, would you warm up your body so that
I think it's, I would just concentrate on the core.
But
And then just
transport, you just keep your blanket.
Or would you do like just
Like, we're gonna take the clothes off, we're gonna pump up the heat in the back, and then just blanket, unless, like, people are still kind of shivering and
He's talking about how.
I might give them a little hot themselves. Some services have like the heated pads and stuff,
You have.
but, yeah, it's kind of like, we're not, we're not really focused on like, my big focus there is like, globally, let's get it warm and then kind of let the body regulate blood flow. Exactly. In which case, you know, they can really see that. They can really do that controlled stuff. Oh, somebody's watching.
I feel,
Yeah, but I still think there's.
How do you watch?
I still think there's.
because even if
You bring up a
you're,
really good.
Like what is
even if
this,
you're just breathing,
link to?
your heart's slowing
It's
down,
just over
like,
YouTube.
you're gonna stop the heart's return. Even if your heart's going only at like 30 beats per minute or 40 beats per minute. Oh, so if you're in total cardiac arrest.
Not the heart.
Yeah, I don't know.
Nick, I was just asking, where do you push epi and
Well, he was.
IVs in someone who's severely hypothermic?
Well, EMTs can do it now.
Yeah, but where?
I know.
You're gonna drill it.
Yeah, so we're either gonna drill, humeral head or tickle plateau.
Yeah.
Then we don't have to worry about, you know, like veins being.
Exactly, I was saying, yeah, you push some epi into the vein and nothing happens till it gets to a certain point of warmth, and it's like, boom.
We can consider drilling this.
We don't have, you need special, ours are only designed for
Humorous or.
I'm
So
sure
you
you,
could
I'm
get-
sure they can.
Yeah.
I'm guessing it has to do with pressure bags, if you see IOs.
We had it, that was the training
Slide
last
into a
week.
pressure bag.
I don't
Just keep an eye, just keep an eye on the schedule.
But if you push it in here, it's
Right,
going.
yeah, and I don't know if you'd be able to even get access anyway, if the AC is clamped down or
Yeah,
anything else.
Because they're probably gonna be so hypertensive that you're not gonna be able to find a vein.
Yeah, anyway,
Yeah. Let alone get like a 14 in there, you know?
Great sacral thing.
Are you an EMT?
Yeah, I work with, Nick and Wilson.
Oh, right.
Oh, yeah.
Good stuff.
Oh, yeah, sorry, I'm Gavin.
I can see you as well.
Yeah.
Nice. What year are you?
Senior.
Oh, yeah. Are you trying to get on the department afterwards or what?
Yeah, I'm applying now. But,
Where you're looking?
San Francisco, that's my, like.
Oh, so you're trying to get out of Colorado.
No, I mean, I want to shotgun a bunch of places in Colorado, California, and.
Brian, it looks a little over 24 hours. See what works out. Small. I mean, it makes
Oregon
sense.
and
Seattle fire would be ready for
There's one I opened up on,
They probably looked at it and said, oh, it's
with an agent.
shit.
So
Anyway, thanks for looking. Yeah, I appreciate that. Yeah, that's some, really hard to parts in.
All right, is everybody about ready to get started up again?
What? What?
Another So, TCCC, Tactical Casualty Combat Care. It's kind of, that's more of the military side of things. There's also TECC, Tactical Emergency Casualty Care. That's more of the fire rescue side. I use the terms a little bit interchangeably in my presentation, so pardon my use of those. Before we get started, I did ask a couple of people to bring their trauma kits. This is generally referred to as an Ipac, International First Aid Kit. Correct me if I'm individual. Thank you. Just want to keep them around. But this is generally what a lot of people on SWAT teams and on deployment are going to have, some sort of little kit like this. So we'll pass this around. This is my little personal one, which is a little bit more in depth, but for the most part, these all consist of enough things to help take care of yourself or your injured patient in the scene of a tactical situation. So we've got the CAT tourniquet, we've got hemostatic gauze, we've got an Israeli bandage, we've got a chest seal, we've got gloves and some tape, and some various little things, bits and pieces. But I'll just pass this around. Please don't open the packages, but you're more than welcome to take things out and take a look at them while we're going. And yeah, some people have the exact same one. So unfortunately, our day of age, we're having a lot of situations where we don't train for tactical situations. We don't work with BCSO or PD or the SWAT team. Some of us are veterans, not me, but you know, some of us have experience working in those sorts of situations, but kind of few and far between. And things like the Boston Marathon bombing, school shootings, that sort of thing, it's unfortunately part of our reality that we might come across a situation like this. So Boston Marathon, there's actually several people whose lives were saved by improvised tourniquets, people acting very rapidly. There's the shooting in Las Vegas last year, same thing, improvised tourniquets saved a lot of lives.
Oh, God. Yes! What a stud. Oh, my God.
It's a little bit of a dark topic, so I had to put a little bit of comic relief in there. But, so some of the things we're going to talk about today is TECC versus care that we provide in more of a rescue, EMS, fire sort of capacity versus that combat or police sort of environment. We're going to talk about, just quick little mention about Stop the Bleed program. I'm going to cover what is TCCC, and then we're going to talk about the steps of care that are part of TCCC. I'm going to try to tie all this together and bring the good, there are bad parts, but the relevant parts to us and try to put it in a more of a useful frame of reference for us when we start to use, so we can use it in our normal day-to-day rescue calls. Well, monthly rescue calls. So TCCC versus the real world. Tactical casualty combat care is generally used when somebody's actively shooting at you. Somebody's down, the shooter's still actively shooting, and there's just not that time to go up and do a full assessment and really go through your ABCs and do a toe assessment, because you're still in the area of danger zone. On both real world and in TCCC, we have limited resources available to us. If we're lucky, we'll have an IFAC, or the patient will have one, or somebody's going to have a tourniquet. More often than not, you got what you got in your pockets, and that's what you got to work with. TCCC, it's more addressing immediate life threats, things that are going to kill your patient within the next 30 seconds. And then we're going to pull them out, and we're going to take them somewhere where we can start doing that more in-depth care. In the real world, we're going to stage for PD. We're going to make sure that they go and clear the scene. We're not going to go into an active hot shooter situation. We're going to stay back, and PD is going to bring the patient out to us. A couple departments across the county and Front Range and in this everywhere practice with PD. EMR Golden and Louisville Fire work very closely with their local PD agencies, and we actually carry full hard plate body armor with Kevlar helmets and everything that we need to actually go in. And then in that sort of situation, we'll have PD escorts, and we'll be in the middle, and our job is kind of extract the patient. Just because it makes sense in the context of TCCC doesn't mean that we should do it every day in our normal job. But our team will bleed. Does that, do any?
GLH atmosphere.
Yeah. We can't stay there all day. We can't, the person's dying, but they're not dying in the back of an ambulance in a hospital. We can't control that situation, so we have to stabilize, do whatever care we can, and get them out to somewhere where we can start to do that more advanced stuff and better assessment. So let's say we have a rollover on a wildland fire. The flame front's coming up at us. Same sort of thing. We have to be able to very quickly assess our patient, get them out to where we can start to provide that more definitive care. Any questions so far? So, I mentioned this briefly, Stop the Bleed. It's more of the civilian-oriented program that the Department of Homeland Security has put out. They're talking very basically about how to use tourniquets, what things to use and things not to do for tourniquets. They talk a little bit about, direct pressure and just basic bleeding control. So it's been a really, really beneficial program. I've had a couple calls where people have, put direct pressure and they've started to, work on the more advanced things that we generally do on the ambulance. It's already all in place and done for us. So, excuse me, awesome program. TCCC originally originated? Well, it originated in the Special Forces in the 90s. I'm not going to talk too much about it because I have a pretty neat video. Again, this overview video is very military oriented, but it kind of gives you an idea of how everything started. Try it. Huh? There we go.
The Naval Special Warfare Research Project in the early 1990s, TC3 is now the accepted battlefield pre-hospital standard of care, based on evidence-based medicine and best practices as reviewed and approved by the Committee on Tactical Combat Casualty Care, or COTC. Tactical Combat Casualty Care, or TC3, was one of the big developments in the wars in Iraq and Afghanistan. The most important measure is how well TC3 keeps our wounded warriors alive to come home to their families. TC3 is different than civilian pre-hospital care. Battlefield considerations and conditions must be taken into account. This study documents that we are now doing that better than ever before, with the best casualty survival rate in U.S. history. Pre-hospital care is the most important aspect in ensuring the survival of the casualty, as almost 90% of all combat deaths occur before the casualty reaches a medical treatment facility. The fate of the injured often lies in the hands of the first responder. Initial care may have to be provided by the combatant. The goal of TC3 is to identify and treat casualties with preventable causes of death and keep them alive long enough to reach the hospital. Previous studies have shown that a significant number of deaths could have been prevented with the use of tourniquets for extremity hemorrhage. Since these studies, preventable deaths from extremity hemorrhage have now been minimized due largely to issuing a new Ipac and training individuals to use it. Although TC3 started in special ops, it is now used by all services in the U.S. military, conventional as well as special ops. TC3 has been a major factor in U.S. forces having the highest casualty survival rate in our history. The approach to TC3 is to identify the causes of preventable death on the battlefield, address them aggressively, and combine good medicine with good tactics. The causes of death for soldiers who died in Vietnam demonstrates that a significant number of deaths occur from problems addressed by TC3, including exsanguination from extremity wounds, airway obstruction, and tension pneumothorax. More recent data from Iraq and Afghanistan show hemorrhage is still the major cause of potentially preventable deaths. We are doing better than ever, but these studies show we still have room for improvement, with between 15 and 28% military preventable deaths. The findings published in 2012 showed that hemorrhage was still the leading cause of death among combat casualties by far. The ongoing mission does not stop just because there is a casualty. The three objectives of TC3 are to provide life-saving care.
We'll cover all this, so don't worry about
to
memorizing
limit the
it.
risk of taking further casualties, and to enable the unit to achieve mission success. Most battlefield casualty scenarios involve making both medical and tactical decisions very rapidly. Remember, the enemy still wants to kill you. The combat environment does not take a time out just because you have a casualty. Doing the right thing at the wrong time can get you and your teammates killed. TC3 divides care into three phases based on the tactical situation. During the gunfight, Attention is focused primarily on eliminating the threat. As the threat decreases, increasing focus is applied to providing the best possible medical care for the casualties. The three phases of care in TC3 are care under fire, tactical field care, and tactical evacuation care. Care under fire is the care rendered by the first responder or combatant at the scene of the injury while he and the casualty are still under effective hostile fire. Available medical equipment is limited to that carried by the individual or by the medical provider in his or her APAC. The key sentence in this statement is that the first responder and the combatant are still under effective hostile fire. Tactical field care is the care rendered by the first responder or combatant once he and the casualty are no longer under effective hostile fire. It also applies to situations in which an injury has occurred but there has been no hostile fire. Available medical equipment is still limited to that carried into the field by the unit personnel. Time to evacuation to a medical treatment facility may vary considerably. Tactical field care allows more time and a little more safety to provide further medical care. But remember, effective hostile fire could resume at any time. Tactical evacuation care is the care rendered once the casualty has been picked up by an aircraft, ground vehicle, or boat. Additional medical personnel and equipment that may have been pre-staged should be available in this phase of casualty management. Tactical and environmental factors have a profound impact on trauma care rendered on the battlefield. Good medicine can be bad tactics. Up to 28% of combat deaths today are potentially preventable. Good battlefield care is paramount in avoiding preventable deaths. In summary, care under fire is the very limited care that can be provided while a casualty and a provider are under.
The video keeps going on for a little bit, but that kind of gives you a sense of where it came from in the specific application that this was intended for. Any questions so far? So we're not going to be working in those sorts of environments, but it's kind of good to kind of keep those in mind. Get going here. So the steps that they talked about were care under fire. So that's when you're actively working in a hostile environment with an active present danger, which really limits your capabilities there. It's a live feed. Huh. Let's turn that off here for a second. There we go. That was very distracting. So, care under fire, tactical field care, that's once you've extracted that patient. So let's say we've pulled our patient out of the car, we've gotten them to the shore, we're in a little bit more sort of safe environment where we can start doing that more advanced care. And then finally we have tactical evacuation care. Military has helicopters and Humvees and everything. We've got ambulances and helicopters. So just different things. Of course, they bring a little bit more capability and resources on their units. So generally, TCCC emphasizes minimal care at the site of an injury. We're doing the very minimum to get the person to survive a couple minutes. If you saw those numbers that were in that video, a large part of those deaths in that sort of environment happens from a sanguination. It's something that we can fix or prevent or slow down really easily in order to get them out. And once they survive that, their chances are a lot higher. Again, limited supplies, medical supplies, limited personnel makes things difficult. So working in the danger zone, like I said, a lot of times you're going to be working, teams are going to be working with people who are actively defending and keeping you safe, and then you'll have one or two people working on medical care. And there's really only two things that we want to make sure that we take care of is massive hemorrhage and airway compromise. I want to point out how stupid this photo is. What do you think is wrong with this?
The launch hot breast.
Oh, yeah, that's not going to be fun. But
He's using the patient as cover?
yeah, he's using the person who's doing medical care as cover. Yeah, he's intubating.
Come on.
And they're actively, well, in this photo, they're firing, they have a gun out, they're pointing. If you're in that sort of environment, like they said in the video, good medicine, doing the right thing at the wrong time can get you killed. So we're not gonna be doing something that's delicate like intubation in the field. It's NPA or OPA and go. We wanna get in that safe position so we can start to provide care.
You didn't say good math, did you?
Not that I remember. It's been one of those days. So once we get him, so you can see active evac, that guy has his weapon out. He's providing cover. A lot of times it's just grab him by whatever means you can and drag him somewhere behind cover. A lot of people, this acronym has been rattling around ever since the introduction of TCCC to the civilian world in March. So that's really the acronym that they use. So it's not airway, breathing, circulation. Number one on that list is massive hemorrhage. So airway, respiration, circulation comes secondary to massive hemorrhage. And then of course, we want to think about hypothermia. We talked about it before. When you have that significant trauma, amazingly more susceptible to hypothermia. So, care under fire. Some things that we can do in that immediate situation is put on a tourniquet on that bleeding. We're going to use BLS airways. We're not going to be like that guy who's intubating with the guy shooting right on top of him. Just OPA or NPA, something really basic, maybe a king tube, and then just get him out. Maybe a chest seal, so that's if somebody's gotten shot in their chest and they have a sucking chest wound. It's just a way to help keep air from going in every time they breathe to prevent their lung from collapsing. And then probably not wound packing or hemostatic gauze. We'll talk about that in a little bit. I've got another video. It's not super, not as great as I'd like, but so these guys are approaching the threat. They're gonna go drag the person out. Unfortunately, I can't control what part of the video it shows, but it kind of shows them that tactical field care phase. Just don't want to go over too much time here. So once we've got them somewhere safe, that's when we're going to start doing that full head to toe assessment. We're going to be a little bit more thorough. We're still working fast. We're going to look for those other big threats. We might start addressing things like, less severe injuries that are bleeding, broken limbs. We're going to start doing more advanced airway procedures if somebody's not breathing at all. The tactical field care generally prefers surgical airways versus intubation, but kind of depending on what where you're working. And then just further continuing that treatment of life-threatening wounds and reassessing tourniquets, reassessing all your treatments. Like I said before, we've got a little bit more field care. This shows, they're in a little bit more protected position. They still have somebody there guarding. Not something that we're really going to see out here. So when we're in the midst of all of this, we want to think about how are we going to get our patient out? What are we going to do to get the patient out of the danger zone to get him somewhere a little bit more controlled? So what's the closest solid object? What ways can we drag the patient? How many people do we have available? Things like that. A lot of times there's a bunch of different drag systems or tarps, blankets, webbing, a lot of different things you can kind of cobble and make work. So back to March, like I said, massive hemorrhage. So we're going to put on tourniquets. We're going to pack wounds. We're going to make sure that we control that bleeding. We're going to make sure that the patient has an open and secure airway, that they're breathing. If they have secretions or damage to the face, we're going to make sure we control that with an appropriate airway. We're going to make sure that they can actually breathe. So do things like put on chest seals. We're going to decompress their chest if they have pneumothorax for advanced life support providers. And we're going to breathe for them if they're not breathing. We're going to make sure that they're perfusing well. So we're going to look at skin signs, capillary refill. So if you squeeze your finger and you can see it blanch, and the time when you let go to where it returns back to normal color, that's what we call capillary refill time. So normally, if you're perfusing well, and you've got warm hands, this is not going to work very well for cold hands, but it should be about 2 seconds or less. That's kind of normal. If it's any slower, it means that they're not perfusing their hands very well, and possibly they're not perfusing their brain very well. So something to think about. And then lastly, we want to make sure that we address any sort of head injuries that we can possibly address, and keep them from getting cold. Wrap them up in a blanket, wet clothing, bloody clothing, something like that, we wanna take that off, get them warm, keep them from getting cold. So approximately 5 liters of blood in the average adult, so that's quite a bit. A lot of times people see like a little bit of blood spilled over, and honestly, this is 250 milliliters, that's actually pretty negligible. When you donate blood, you give about 2 of these, and there's, you might feel a little bit woozy, you might feel a little bit dizzy, but it's really not that big of an insult. And if I were to take this and just fling it around the room, it would look like I can't think of the word, but it would look like a slaughterhouse. It really would, and it's really easy to overestimate the amount of blood loss. But just keep in mind that 5 liters is a lot. Generally, that if you like the number, 70 milligrams per kilogram, you can calculate. So for massive hemorrhage, let's say we have a complete compromise of the femoral artery. How long do you think it would take to bleed out from that femoral artery compromise? 2 seconds, minutes? 3 minutes, 180 seconds. So in this case, I think it was a soldier who had makeshift tourniquets put in place that ended up saving his life. But think about 2 compromised femoral arteries. That's your time very down a lot. So that's where it's so important to recognize that massive hemorrhage and do something about it as soon as possible. Again, don't focus so much on the numbers, but look at the symptoms, that from mild to severe. So here, the person's still alert. They're still talking to you. They're still oriented. They're able to follow directions. Their pulse is still strong, so if you can feel their radial pulse, it's nice and strong. Their heart rate might be a little bit elevated, but it's not really fast. Again, if somebody has blood loss, they're probably a little bit anxious, they're probably in a little bit of pain, so their heart rate's going to be naturally elevated. Their blood pressure is normal, they're breathing normally. They're not that 12 to 20 range of breaths per minute, they fall right in there. Again, now we're moving up to a little bit more severe. They're starting to be anxious, they're moving around, they're squirming, they're scared. They might be combative, like, no, don't touch me, go away. Leave me alone. Their pulse is still nice and strong. Heart rate is a little bit increased. So the further we get down here, we'll see that the radial pulse starts to go away. That's about 90 millimeters of mercury systolic. So if you, when I assess my patients and I'm looking for good perfusion, I'm looking for mental status. Are they awake? Are they talking to me? Or are they kind of sluggish and falling asleep? And I'm feeling their pulse. Is it regular and strong? Or is it weak, or is it absent? That's going to tell me a lot when I start to put those things together. So the more blood we lose, the less mental status they have. We're going to see kind of that 15 to 30% loss. They're starting to breathe a little bit faster. But when they're starting to breathe at 30 times a minute, that's when it starts to get serious. That's another big sign that stands out to massive trauma and blood loss. Now, we're going to have severe mental status, really fast heart rate, cool, pale skin. They're not going to have a radial pulse. And of course, they're going to be unconscious when it's really severe. So any questions about blood loss? Again, when we're assessing wounds for blood loss, the big things that we're looking for is active spurting blood. We're looking for blood that's really pouring out. Anything that's really pooling or oozing, it doesn't really qualify as that massive hemorrhage. So it's really not a big deal if you over-treat one of those and you put a tourniquet on, but try to make sure that you really assess everything. So speaking specifically of tourniquets, there's a couple different brands out there. It's really easy to get a cheap one, or a fake one. People who do airsoft and paintball and that sort of thing, they like to wear replica equipment and look like military. And a lot of times you have companies that knock these off so they can wear them and look more like the part. And unfortunately, it's very difficult to differentiate them. So the real place to get these is directly from the manufacturer. And I'm just going to tell you guys, don't buy a tourniquet. Just wait a couple days. And we'll figure that out later. But for the most part, the cat tourniquets are really standard. You'll also see another one called soft T. That's another big one. But essentially, what these have is a nice adjustable Velcro band. They have this handle here, which is called a windlass. So this turns and it pulls. There's an internal bit of webbing in here that starts to constrict. And then we've got a couple different mechanisms to secure it. So these are pretty much the industry standard. These are what most people are using. You've got a couple different options, at least with the cat tourniquet. So you can take it apart completely and put it around a limb and then tighten it up, or you can open up with a loop and pass it over. So it is pretty versatile. You have a couple different ones, like that soft T has a little buckle there. It's a little bit different to secure. What I recommend is when you get a tourniquet, make sure you watch the manufacturer's videos on how to use it. Get familiar with it, and make sure you find a training tourniquet. If you have a tourniquet that you're using in one of your medical kits, if at all possible, try not to use it for practice too much. The more you use it, the more it wears down, and it could break at a critical time. So really avoid that if possible. On these cat tourniquets, they come out of the factory stored pretty strangely and really inefficiently for actual use. So I actually have it open to a nice wide loop here so I can pass it over everything. You'll see a lot of people, they store the windlass over here with the tape above. When that adrenaline dump happens, those fine motor skills are really going to go, and if that's not the epitome of fine motor skills picking that off, I don't know what it is. So best way to store these is make sure that you have that nice and open, so at least you can get that windlass, you can control bleeding, and stop it there. I'll go over how to use these in a little bit. Other considerations, make sure that you have it accessible in a medical kit. Of course, we're not working in that military or tactical situation, but just make sure you know where it is in your bag. If you're hurt yourself, or if you don't have if you don't have easy access to your bag, make sure that you can describe where it is to somebody so that they can use it. So procedure, when we're putting on the tourniquet, the saying used to be high and tight for TCCC. That's a big difference between the civilian world, where we're going to expose, we're going to really make sure that we assess the wound before we put it on. And we're not, civilian world, we're not going to put it on any higher than we have to. TCCC, when in doubt, they put it high and tight, so as high as they can, even for forearm injury, put it tight. Something that we want to avoid is putting it over any sort of joint or rigid object, especially if somebody has lots of crap in their pockets. Make sure that you put it above, or you take the stuff out of the pockets and then you apply the tourniquet. Another thing that we want to do before we fully apply it, so if I'm injured and I have to put the tourniquet on myself, another good thing to practice is be able to put it on yourself, and think about putting it on with one hand, or you have limited mobility. So when we put it on, we want to crank it as tight as we can before we start lining this. Especially with these cat tourniquets, if we have to spin this more than 3 times, it's not tight enough. So the more slack you pull out initially, the better it's going to work and better it's going to compress. Something else to think about is that whenever we use a tourniquet the right way, it's going to hurt. It's going to hurt a lot, and it might hurt even more than the injury that you're trying to treat initially. Doesn't mean that you're doing anything wrong, and it doesn't mean that you should slack off. Our big thing is we want to control the hemorrhage. We want to control that bleeding. So talk to your patient. Make sure you let them know that it's going to hurt, but we're saving their life. And then if the case that for some reason we're just not in a good position with that tourniquet and it's still not stopping the bleeding, take a second one, you leave the first one in place and you put it right above, closer if possible. So, any questions on application? Again, I want to get a training tourniquet so we can actually get hands-on and start to build that muscle memory. The big thing on any sort of your medical kits or this medical equipment is make sure you keep practicing. You get it out on a regular basis and you're familiar with it, because when the big call happens, it's really easy to get that big adrenaline dump and get that fine motor skill and get that fine, get your mind rolling. It's really difficult. So reverting back to muscle memory and things that you've trained on 100 times is really going to help you work a little bit smoother. If you're interested, 1150 on the Boulder County protocols, it outlines all of this for you EMTs. It should be pretty much second knowledge. The big things that differ from TCCC and civilian world is that we're going to take an extra second or two. We're going to expose whenever possible with our shears and make sure that we get a good visualization on an injury. TCCC, you may or may not have that time. If you're providing care under fire versus that tactical field care, the only thing you might do is see a big pool of blood. You might see some active spurting blood or soaked clothing, and just go straight for that tourniquet. So like I said before, indications: bright red blood, it's spilling, it's pouring. That's definitely not something I would go straight for a tourniquet in the civilian world. That's something I'd try direct pressure on first. A constant stream, a pulsating stream, of course those are all big indications. Pooling blood, and then soaked clothing, so significantly soaked. So if they have like a t-shirt or a sweater on, it's soaking through that. That's when we want to start thinking about tourniquets. And of course, massive extremity damage, including amputation. So if you have an open fracture that's really big, keep that in mind. A lot of mistakes. So waiting too long. Like they said, the biggest leading killer on the battlefield in tactical situations is hemorrhage. So the faster we can get this on, the less the patient bleeds out, the less chance they have of going into severe shock, the better we can treat for them, the better their outcome's going to be. So identifying that bleeding and making sure that we get the treatment as soon as possible is key. Not pulling out all the slack, I talked about that. Tourniquet used for minimal bleeding, while it's not the end of the world, if we can, it's difficult if you don't have a lot of experience around wounds, but if the wound doesn't need it and you don't use a tourniquet, that's going to be better for the patient. Proper tourniquet use can result in some nerve damage long term, but for the most part, they've had people with tourniquets on for 8-12 hours, even longer, with very, very minimal lasting side effects. So we're not really doing the old thinking of, we're letting loose every 30 minutes to reperfuse. Once it's on, we don't touch it. Even for minimal bleeding, we're not reassessing and letting loose. It's on until we get to definitive care. And then the other 2 points of not getting to a second tourniquet or not putting it tight enough. The biggest indicator that you're doing it right is that it hurts your patient and that the bleeding stops. So just keep that in mind. So looking at some other injuries, what would you say for these injuries? Tourniquet or no tourniquet?
Far right, no.
Okay, so no, wait, where's my little fancy pointer? So no amount, okay. That could be a gunshot wound, but again, we're not seeing that steady stream of blood. We're not seeing it pooling. What do you think on that one?
Certainly not spurting.
Yeah, it's, again, little stream. It's not actively gushing. Perfect, yeah, direct pressure. If that doesn't work, then we're going to start thinking about more advanced measures. Then of course, we're talking about soaking. It's not that much.
Exposed first.
Yeah, exposed, exactly. Depends on what kind of situation you're in. But in our world, that's where we're gonna take a second, fully expose, see what's going on underneath. So I touched on this very briefly, the chest seals. This is a improvised one. It's a little bit difficult to see, but what they have is a thin plastic film right here, and they've got it taped on 3 sides. So that provides a sort of vent. So when you exhale or when you inhale, your diaphragm pulls down. It creates negative pressure in your thoracic cavity, which pushes air into your lungs. When you exhale, it's the opposite. So if you think about, when you have a compromise in your chest wall, when you have that negative pressure in your chest, it's gonna pull air in here, but it's also gonna pull air into the hole, and vice versa. So when you exhale, it's gonna push air out. So that's what's called a sucking chest wound, is when you have that air movement. A lot of times, punctures, penetrations, stabbings, that sort of thing is when we see that, ballistic injuries. We just wanna make sure that the biggest thing you can do, if you don't have that film in place or anything, cover it with a hand, you can keep it plugged. The nice thing about this little three-way little package here is that it's self-venting. These kits have a commercial chest seal. Something to think about, again, if you're not EMT or above, not that big of a consideration for you guys, but just keep in mind, you can always cover it with your hand.
I've also heard people say that you want to seal all four sides and just occasionally burp it. What's best practice or evidence based?
Whatever you've been taught.
Okay.
I don't want to get too much into it, but these things the seal doesn't always work, so if you have four sides, you just have to keep in mind that you'll have to occasionally let the pressure off inside. It's not going to self. Commercial ones self-vent pretty well, they seal pretty well. So we've talked a lot about the something that's not really our domain in our world, but something that is start triage. So we use start triage in the situation where we have more patients than we have resources. Again, sounds kind of familiar. So especially when we have like a big car accident with several patients, we have to make sure that we get to the priority patients first. The big thing with start triage, if you haven't heard of it, is pretty much RPM, respirations, perfusion, and mental status. So are they breathing or not? We're gonna try once to readjust their airway. If they start spontaneously breathing or assume a more normal breathing rate, they're red. Then we're gonna go to perfusion. If they're pale, cool, and they don't have a good radial pulse or a capillary refill, immediately they become a priority patient. If they have a good pulse and respiration, then we're gonna go to mental status. If you go to your patient, you say, you ask them, what's your name? Can you point to where it hurts? And they can follow those commands, that means they're a little less severe. If they're disoriented, they can't follow those basic commands, they immediately become reds. Trauma reds are the priority patients. So we want to make sure that we go through as many of our patients as possible in the least amount of time, identify those priority patients. Our yellow patients are people who could, it's called delayed, or they're people that can wait a little bit. They don't need that tourniquet right away. They don't need that airway management. They don't need IV solution or blood products. They can wait a couple minutes, a couple hours before they get care. And of course we have our minor. The first thing that you do when you get on a big scene like that is, hey, everybody who can walk, come towards me. Get them, separate them from the scene. If somebody can stand up and walk and get to a safe area, they're more likely than not, they're very badly injured, and they could probably wait even longer than those trauma yellows. There's some specific little numbers in there. EMTs should know this. So if you haven't reviewed Start Triage, take a look over it. There's a lot of good videos on YouTube and flow charts and everything like that. But on a big call, when we have multiple patients, that's the kind of thing that we're going to default to, is looking at respirations, breathing, and mental status, and really sorting out from there. March, talked about it, keeps coming up. It's a really good acronym to remember when you're checking your patients, going through and figuring out what's going on. Any questions so far? So I think we're gonna take this out to the base. I've got a couple patients laying down, and I'm gonna show you guys how we do our head to toe assessments. If some people wanna try practicing doing a head to toe assessment, we can do that. We've got some simulated injuries that Justin helped me out with, and we'll go from there. Cool. Making sure I remember what's here. Okay.
Yes. Have you done that? No, it's super. Oh, I heard.
Oh, thanks, Bob.
There's girls around there aren't too bad, but going up to the airplane.
Oh, well, nobody's even watching, so I don't know.